Alopecia areata is a chronic, inflammatory condition affecting the hair follicles, which leads to sudden onset of non-scarring alopecia, hair loss where the hair follicles are generally preserved. Any hair-bearing skin can be involved, but it most commonly affects the scalp or beard and, less frequently, the eyebrows and eyelashes. Hair loss is usually patchy, producing circular or oval areas of loss. Diffuse hair loss is more unusual. Total loss of scalp hair, alopecia totalis, or scalp and body hair, alopecia universalis, is uncommon. There may be a band-like pattern of hair loss at the occipital and temporal scalp margin, ophiasis pattern, or hair loss at the vertex with occipital and temporal sparing. Occasionally, there may be an overnight graying, or white overnight effect due to loss of pigmented hairs with sparing of white hairs. Nail changes are seen in 10 to 15% of people with alopecia areata, typically those with more severe disease. Alopecia areata is thought to be an autoimmune disease and occurs when hairs are prematurely converted from the growth anagen to the loss telogen phase, resulting in dystrophic, miniaturized hairs. The cause of alopecia areata is unknown, but multiple factors are likely to be involved, including genetics. About 20% of people with alopecia areata have a positive family history. Observed heritability in first-degree relatives and twin studies further supports a genetic basis for the condition. Autoimmune reactions, defects occur in localized immunosuppressive mechanisms which are thought to be T-cell mediated. The anagen hair follicle is usually a site of immune privilege, where mechanisms prevent autoimmune attack. It is theorized that in alopecia areata this is disrupted due to T-cell interaction with aberrant antigens expressed by hair follicle keratinocytes. There is an association with other autoimmune conditions, including systemic lupus erythematosus, thyroiditis, vitiligo, pernicious anemia, and atopy. Stressful life events may be related to the onset and/or progression of alopecia areata. Lifestyle factors. Smoking appears to increase the risk of alopecia areata, and there is speculation but no strong evidence that other lifestyle factors such as alcohol, obesity, diet, and sleep disturbance may be involved in pathogenesis. Neurogenic. Changes in the peripheral nervous system may alter the release of neuropeptides and influence inflammatory reactions. Possible complications of alopecia areata include psychosocial impact, altered body image, reduced self-esteem, social withdrawal, increased risk of anxiety, depression, adjustment disorder, and possibly an increased risk of suicide. Behavior change, particularly in children, including school refusal and reduced academic performance. Reduced quality of life. The prognosis of alopecia areata is unpredictable and variable in different studies. Disease extent and pattern at presentation are predictors of long-term outcome. There tends to be unpredictable episodes of relapsing and remitting disease. Note that the literature varies considerably in reports of remission and progression rates, although there is more consensus about prognostic indicators. Spontaneous remission within 1 year may occur, with studies suggesting this occurs in between 34 to 50% of people. Hair regrowth is more likely in those with limited patches of hair loss of less than 1 year duration, but most will later experience further episodes. The British Association of Dermatologists, BAD, guidelines quote a 1965 paper from Japan where spontaneous remission within a year was reported in 80% of patients with small numbers of circumscribed patches of hair loss, but also notes that data from referral centers indicates less favorable spontaneous remission rates of 34 to 50%, which is in line with figures quoted in the more recent expert reviews. It has been estimated that 15 to 25% of people with patchy disease will progress to develop alopecia totalis or alopecia universalis. Fewer than 10% of people with extensive disease have a sustained remission. A person may experience several episodes of hair loss and regrowth during their lifetime. A poorer prognosis may be associated with onset in childhood, family history of alopecia areata, long-standing, extensive alopecia, including alopecia totalis or universalis, involvement of the scalp margin, ophiasis, and/or nails changes, a history of atopy or other autoimmune diseases such as systemic lupus erythematosus, thyroiditis, pernicious anemia, or vitiligo. History and examination. Suspect a diagnosis of alopecia areata if there are typical clinical features, and if other causes of hair loss have been excluded. Hair loss typically affects any hair-bearing area, most commonly the scalp or within facial hair such as the beard, and is usually patchy and of sudden onset. Patches of hair loss are usually round, well circumscribed, and smooth. Patches may coalesce into larger areas of alopecia. More rarely, hair loss may be diffuse. The skin is normal colored or slightly red without scarring. The follicular openings are still present. Exclamation mark hairs, short broken hairs which taper proximally, may be seen around the margin or in any part of the patch during active disease. Hair loss is usually asymptomatic, although occasionally itch, tingling, burning, or pain may occur prior to hair loss or with disease activity. Where symptoms such as these are present, other causes such as tinea capitis should be considered and excluded. Nail changes may occur and include pitting, onycholysis, loosening, splitting, longitudinal ridging, red lanula, koilonychia, concave outer surface, and leukonychia, white patches under the nails. History. Ask the person about how the hair loss is affecting them and the impact on their self-confidence, self-esteem, and quality of life. Any known triggers such as emotional stress, and any associated anxiety and/or depression. If identified, these should be managed appropriately. Their diet and nutrition, their coping strategies and social support network, any previous episodes of hair loss, any current or past treatments, including over-the-counter preparations, and their effectiveness, any family history of hair loss, any history or family history of associated atopy or autoimmune disease, such as systemic lupus erythematosus, thyroid disease, pernicious anemia, or vitiligo. Examination. Determine the nature and extent of hair loss on the scalp, patchy, diffuse, total, ophiasis or sisafo pattern, and other sites, including eyelashes, eyebrows, axillary, and pubic hair, if appropriate. Severity at onset may impact management choices and prognosis, poorer outcome with more extensive disease, so it is helpful to assess this. Alopecia areata is considered severe when more than 50% of the scalp surface is involved, mild when it is patchy and involves less than 25% of the scalp, and moderate between these two categories. Check for signs of skin inflammation, erythema, scaling, or scarring, which may suggest an alternative diagnosis. Assess for evidence of hair regrowth, short, fine, tapered hair, or depigmented hair, which affects options for management. Assess for any associated nail changes. Consider performing the pull test to identify if there is active hair shedding. This involves grasping a small section of hairs at the periphery of a hair loss patch between the finger and thumb, about 50 to 60 hairs, and tugging gently but firmly. It should not be painful, sliding the fingers along the hair shaft. The test is positive, confirming active shedding, if more than 3 hairs, or greater than 10% of hairs, are pulled away from the scalp. Note: the test shows high inter-observer variation, and the definition of how many hairs constitutes a positive test varies in the literature. Investigations. Routine investigations are not usually needed, but consider the following tests if there is diagnostic uncertainty or atypical features. Full blood count, ferritin, and thyroid function tests, particularly if telogen effluvium is suspected. Skin scrapings and hair samples for fungal culture and sensitivity. In secondary care, or where there is expertise in primary care, trichoscopy, use of a dermatoscope, and skin biopsy may also be helpful where there is diagnostic doubt. Typical features on trichoscopy include the presence of yellow dots, black dots, dystrophic and damaged telogen hairs, broken hairs, or the classic exclamation mark hairs at the borders of the affected areas. Following skin biopsy, histopathology may show a bee-swarm pattern of dense lymphocytic infiltrate around anagen hair follicles and a decrease in the ratio of anagen to telogen follicles. Routine testing for associated autoimmune conditions is not recommended. Differential diagnosis: patchy hair loss, tinea capitis, trichotillomania, a psychiatric condition where people pull their own hair out. Hair loss is typically incomplete, asymmetrical, and has an unusual shape. There are usually multiple broken hairs of varying length. Single or multiple areas may be affected, including eyebrows and eyelashes. Traction alopecia, hair loss secondary to pulling on the roots, commonly caused by hair styling techniques, for example tight braids or ponytails, and usually involving the scalp margins causing temporal hair thinning. Androgenetic alopecia: there is a typical pattern of hair loss over the crown where pigmented terminal hairs are progressively replaced by finer hairs. Both men and women can be affected. In women, hair loss may be more diffuse, with a reduction in hair density over the crown and frontal scalp, with the frontal hairline usually preserved. Scarring, cicatricial alopecia, caused by inflammatory disorders that target and destroy the hair follicle, resulting in permanent alopecia, such as scleroderma, discoid lupus, lichen planus, or shingles. Secondary syphilis typically causes a moth-eaten, patchy hair loss. Diffuse hair loss differentials: telogen effluvium describes the loss of individual hairs earlier than normal because of a more rapid hair growth cycle, often associated with profound shedding or a rapid onset of hair loss. Acute generalized telogen hair loss over the whole scalp can occur about 3 months after a significant event, such as physical or psychological stress. Bitemporal recession is a common sign in women. Hair loss lasts for 3 to 6 months, and then the hair regrows. Telogen gravidarum is telogen hair loss typically seen 2 to 3 months after childbirth. Chronic diffuse telogen hair loss can occur as a result of stress, thyroid disorders, iron deficiency anemia, and malnutrition, but often no cause is found. Anagen effluvium describes drug-induced hair loss, for example following chemotherapy, tricyclic antidepressants, allopurinol, beta blockers, nitrofurantoin, or retinoids. Management: if a person presents with suspected alopecia areata in primary care, provide information about the condition and explain that. People with alopecia areata with mild hair loss often experience hair regrowth within a year, but this may be unpredictable. Various medical treatments may help to induce hair regrowth, but cannot cure the underlying condition, and future episodes of hair loss may occur. It is uncommon for alopecia areata to result in total hair loss. Advise on the use of sunblock and/or a hat to protect hair loss patches from sun damage. Consider the need for psychological support. Contact with patient support groups may be helpful, but there may also be a need for referral for additional psychological support, such as counseling or cognitive behavioral therapy. For children, if there are changes such as being withdrawn, achieving less well at school, changes in behavior or mood, a referral to a child and adolescent mental health service may be appropriate. Treatment and advice: provide advice about treatment options in primary care. If there is evidence of hair regrowth, short, fine, tapered hair, or depigmented hair, advise that there is no need for treatment. If there is no hair regrowth, but there is a limited amount of hair affected, it is stable and not conspicuous and not causing distress, then watchful waiting may be appropriate. If there is no hair regrowth, but the person chooses not to have treatment, and there is no psychological distress, then no treatment is a reasonable option, which can be reviewed if the situation changes. If there is no hair regrowth and the person wishes for treatment, discuss the options. Consider a trial of a potent topical corticosteroid in adults, such as betamethasone valrate 0.1%, fluocinolone acetonide 0.025%, or hydrocortisone butyrate 0.1%, or a very potent topical corticosteroid, such as clobetasol propionate 0.05%, for 3 months. Off-label indication: a lotion, foam, or scalp application/shampoo preparation may be prescribed depending on individual preference. Note: do not use potent corticosteroid preparations on facial areas such as the beard or eyebrows. Advise that hair regrowth may not be seen for at least 3 months after starting topical preparations. Advise about potential side effects from potent topical corticosteroid treatment, such as skin changes, telangiectasia, folliculitis, and acneiform eruptions, systemic absorption. Advise that if hair regrows, it is often initially fine and depigmented before it returns to its original color. Advise that hair can be dyed if it is slow to repigment, ideally following discussion at a hair salon. Advise on cosmetic options to camouflage hair loss, not available on NHS funding, including hairstyling, waving, dyeing, sprays, and mousses. Hair camouflage, such as a keratin microfiber product which may provide scalp cover, or hair color root touch-up products. Hair extensions provide fullness but may result in further pulling and traction on existing follicles. Dermatography, tattooing, semi-permanent makeup can be used to create the appearance of eyebrows. False eyelashes, headscarves, and hats. Advise on the option of using hairpieces and wigs if needed and appropriate. Specialist management. There are multiple specialist dermatology treatment options for alopecia areata. The management approach should be based on disease duration, activity, location, extent, and the person's age and individual preference. Intralesional corticosteroids, multiple intradermal injections, commonly hydrocortisone acetate and triamcinolone acetonide, are given into areas of hair loss and repeated every few weeks. It is particularly suitable for limited, patchy hair loss and for cosmetically sensitive sites such as the eyebrows. Hair regrowth is stimulated at the site of injection, but the effect is usually temporary, lasting a few months only. Adverse effects include local pain at the injection site, skin atrophy, and skin depigmentation. Oral corticosteroids. There is conflicting evidence regarding the benefits of oral corticosteroids, for example, for the treatment of extensive or rapidly progressive disease. They may be given as continuous or pulse treatment and may take the form of a 6-week tapering course. Possible benefits should be weighed against potentially serious adverse effects and the risk of relapse after stopping treatment. Topical immunotherapy. This may be offered in specialist centers to people with extensive patchy hair loss. The aim is to induce a low-grade allergic contact dermatitis, which alters the immune response and induces hair regrowth. This is achieved by sensitizing the person to a potent contact allergen initially applied to a small area of the scalp, which is then applied at increasing concentrations. Adverse effects may include blistering, lymphadenopathy, and skin pigmentation changes. Topical minoxidil has been used, but hair growth is generally not considered to be cosmetically adequate. Dithronol, not used routinely as the evidence base is weak and it stains skin and hair. Psoralen plus ultraviolet A light therapy, PUVA. There is limited and conflicting evidence for the use of light therapy in the treatment of alopecia areata. Adverse effects include nausea, skin pigmentation changes, and an increased risk of skin cancer, and this is rarely now used. Immunosuppressive drugs, oral cyclosporin or methotrexate, may be offered to people with extensive alopecia areata, but trial evidence is very limited with small patient numbers and uncontrolled trials. Drug use is limited by potentially severe adverse effects, and relapse may occur after stopping treatment. Biological agents. Recently, there has been evidence from trials that oral Janus kinase (JK) inhibitors may be effective, and baricitinib is the first of these to have had marketing authorization for the treatment of severe alopecia areata in Europe and the USA.